Okay, we're starting lecture 27, so we're transitioning from blood products. We are now moving into the mom and baby section. We're going to be talking about hemolytic disease of the newborn and identifying what type of hemolytic disease of the newborn. All right, so if any of you guys have been struggling with BloodBank up to this point, we put everything together that we have learned so far into moms and babies. So antibody identification, providing antigen negative blood, interpreting DAT results, what's causing the hemolytic disease of the newborn, all right? This is actually one of my most favorite things to do in BloodBank, and so I hope you guys enjoy it as well, okay? All right, so hemolytic disease of the newborn, you might also hear it referred to as hemolytic disease of the fetus in newborn, maybe abbreviated HDFN. It is technically called erythroblastosis fetalis, all right? And that just means that mom's IgG antibodies are now coating baby red cells, and those cells are being destroyed, causing anemia in the baby, respiratory distress in the baby, and if it is severe and goes untreated, can result in fetal death, fetal loss, all right? All right, so you have to think about what's occurring with the fetus. The umbilical cord sends mom's blood to the fetus for nutrient supply of the fetus. What happens is in that umbilical cord, there are mom cells and baby cells, all right, in the fetal maternal exchange. In the event of a trauma, all right, so if mom is, let's say 32 weeks, she's in a car accident, there is a direct impact into her abdomen, it could result in baby cells being exposed into mom's circulation, right? That's the problem. So anytime there's a trauma, and even in delivery, there will be a small exposure of fetal cells into mom's circulation, okay? So what happens is if mom is exposed to baby cells, then she could build an antibody. Okay, so I want to say this, there's really two different types of hemolytic disease of the newborn. One is due to ABO incompatibility. So if mom is O and has an A baby, mom's anti-A, B can cross the placenta and coat baby cells. All right, that can happen in a first pregnancy. Okay, that can happen in any pregnancy. However, an IgG other red cell antibodies such as D or little e or KEL, Duffy A, Duffy B, JKA, JKB, those antibodies have to be built on exposure, correct? So if baby is D positive, mom is D negative, in the fetal maternal exchange of that current pregnancy, and mom hasn't built the antibody yet, that pregnancy is fine, all right? Nothing wrong with that current pregnancy. However, if it's D we're dealing with, and she does not receive ROGAM to prevent her from building anti-D, and she builds anti-D, it could cause harm for her future pregnancy. Okay, so ABO can affect first pregnancies. IgG antibodies will not affect the current pregnancy. It affects the subsequent pregnancy. Right, does that make sense to everybody? All right, so that's why when we're dealing with females and she's pregnant, we always want to know how many pregnancies has she had. Okay, and remember, in order to build an IgG antibody, you can build antibodies from exposure through transfusion or pregnancies. Okay, so if baby is positive for the antigen mom lacks, and in the fetal maternal exchange, mom can build that antibody. Okay, and remember, anti-D is the only one that we have prophylactic treatment for. That is our ROGAM. Okay. All right, so small bleeds occurring occurs in about 50% of pregnancies. Not all of them mom will build an antibody to, but it can happen. All right. And if there's any type of trauma, then larger bleeds could occur, exposing mom to that a higher amount of those antigens. All right, so just what I talked about in that fetal maternal exchange, mom is exposed to baby antigens. She's going to build an IgG antibody. It will affect her future pregnancies, okay? And so what happens is the baby inherits an antigen on its red cells from the father that the mom is negative for, okay? Does that make sense to everybody? So the baby is antigen positive, mom is antigen negative. During the fetal maternal exchange, mom is going to be exposed to baby red cells. She could potentially build the IgG antibody to that red cell antigen. And then what's going to happen is if mom has that antibody in a future pregnancy, baby is antigen positive, mom's antibody will coat baby cells, and then the baby's spleen is going to destroy those cells. While the baby is in utero, the baby might have anemic symptoms, but the bilirubin is not such a concern because mom's liver can clear the unconjugated bilirubin. Okay, mom's liver can conjugate it. However, once that baby is born and those cells are still coated with antibody, the baby's liver is very immature. It cannot clear, it cannot conjugate that bilirubin. And that is why babies have, that this occurs in hemolytic disease of the newborn. Babies have an increased bilirubin, and that's going to cause their spleen to be enlarged, all right? Their bone marrow is trying to compensate for that anemia. Spleen is trying to be involved in extramedullary hematopoiesis, so they have abdomen swelling, okay? So that's the #1 thing that you'll see in hemolytic disease of the newborn. If that bilirubin is not clear, and bilirubin passes the blood-brain barrier and gets to the brain, it can cause kernicterus. Okay, which is very fatal for babies, right? That's why oftentimes you might see babies, they have to be put under the UV light. And we're going to talk about why that is. Or maybe their bilirubin is not so severe, they can go home, but the physicians encourage babies to sit in natural sunlight because the light will break down that bilirubin into an excretable byproduct. Okay, and so that will decrease the bilirubin in those babies being under the either natural light or in the UV light. Okay. So hydrops fetalis in your fetus characterized by edema. So usually you're going to have abdomen swelling, symptoms of anemia, and that abdomen swelling, #1, because the spleen is involved in extravascular erythropoiesis, and part of the edema. They're going to have excess fluid collection in their abdomen as well. That's what causes, and if they have kernicterus, it can even cause swelling in the brain. Okay. So Sarah asked what the ABO example you used in the first pregnancy. So you would see hemolytic disease of the newborn due to ABO if mom is type O. All right, and we're going to talk about why. So typically you'll only see hemolytic disease of the newborn due to ABO incompatibility if mom is type O, because group O people produce anti-A, B, which is IgG and can cross the placenta. Okay, so think about our other ABO antibodies, anti-A, anti-B, those are IgM. They can't cross the placenta. However, the IgG A, B antibody can cross the placenta. All right, so that is why it has the capability to cause hemolytic disease of the newborn due to ABO incompatibility. So mom would be O, baby would be either type A or B. Okay, so that would be a incompatibility of ABO. So what happens is mom's anti-A, B attaches to those A cells or those B cells. All right. Same thing for RH. So if mom has anti-D, baby is RH positive, mom's anti-D can coat those RH positive cells, and then the baby spleen is going to remove those cells, causing anemia in the baby. And we're going to talk about the differences between ABO and hemolytic disease of the newborn due to another IgG antibody. ABO typically is a milder case, so they can probably, they'll have maybe small amount of anemia, small amount of bilirubin. They can go home and sit in the natural sunlight. They'll be fine. If it's an IgG antibody such as D or Kel, that causes more harm, all right? Then those patients will probably have to stay in the hospital and be under the UV light. But the thing you need to know is ABO, hemolytic disease of the newborn, can occur in that first pregnancy. Doesn't have to have prior exposure, right? She has that antibody naturally, okay? For D or Kel or E or Duffy A or Duffy B, she has to have some type of prior exposure, a previous pregnancy or a previous transfusion. Okay. All right, so here's just a schematic of clinical effects of hemolytic disease of the newborn when the baby is in utero, okay? So here's your incompatible fetus, whether it be ABO or another IgG antibody. Mom's antibody coats baby cells. Those cells are going to be destroyed by the fetal spleen. Hemoglobin is going to be released and broken down into indirect bilirubin, where it's going to cross the placenta and go into mom's liver. Mom's liver is able to conjugate that bilirubin and clear it, okay? So while anemia might be concerned for the baby in utero, the bilirubin does not affect until birth. Okay, so see what happens after birth. So here's your newborn, all right? Mom's antibodies still in baby's circulation, right? So we still have some antibody-coated cells. The infant spleen is going to destroy these cells. The hemoglobin is broken down into indirect bilirubin. The infant's liver is incapable of conjugating that bilirubin. So you're going to have increased levels of bilirubin in baby's circulation. That is what causes the baby's jaundice, and that is what is so harmful to the baby, again, because it can cause kernicterus. Does that make sense to everybody? It's the mom's liver that conjugates that bilirubin. Okay. All right, so again, in utero, anemia is the problem. Bilirubin is not a concern as long as that baby's in womb. And then after birth, the baby's still going to have anemia, but then also going to have high levels of bilirubin in severe cases of hemolytic disease of the newborn. All right, so we use phototherapy. They will put the babies under the blue UV lights. And what happens is that phototherapy converts that unconjugated bilirubin into a byproduct that the baby's liver can then excrete. So it helps the baby clear that bilirubin, preventing the kernicterus. Okay? And usually the blue light is at 420 to 475 nanometers. If the hemolytic disease of the newborn is so severe that the UV light does not work and they need more therapy, then that is when a neonatal transfusion exchange occurs. And what that means is we're going to pull out some of those baby cells that are coated with mom's antibody and give them fresh donor cells. Right, so usually they pull off a desired amount, maybe 25 mils, right, so they pull that out and then they transfuse the exact amount that they pull out. So if they pulled out 25 mils, then they would give 25 mils of fresh donor red cells. Okay, you guys remember the requirements for a neonatal exchange. Has to be fresh, less than 5 to 7 days old, CMV negative, irradiated, leukodepleted, and remember, they cannot be exposed to Adsol. So it has to be either CPD, CPDA, CPD2. Okay? If you don't have any of those anticoagulants available and you have to use Adsol, those red cells must be washed. All right. Kate, you have a question?
So how would natural sunlight compare to the UV light? The reason I'm asking is someone I know was born outside of the country and they didn't have UV light in Panama, and so they would put the babies in direct sunlight.
So the UV light is going to be more fast acting. It's going to have a larger impact. So that's why if the bilirubin is at a higher level, they recommend the UV light. However, if it's mild, just a low amount of bilirubin, I think less than 14 then the natural light can slowly break down the unconjugated bilirubin. Notice here it says that if that bilirubin level exceeds 18 to 20 milligrams per deciliter, that's the level that a exchange transfusion might be warranted, right? So the higher the bilirubin, the more severe the case of hemolytic disease of the newborn. Right, so some factors that cause hemolytic disease of the fetus and newborn. Again, the red cell antibody is coming from the mom. All right, remember, babies can't build antibodies until about 6 months of age. All right, so whatever antibody is coding cells, whatever antibody is in the baby's circulation, it's maternal. It came from the mom. That's why when we do our baby testing, if we were to do an ABO-RH and we did an IAT on the baby's plasma, if there's an antibody in baby's plasma, it's maternal, all right, up until 6 months of age, because they cannot build antibodies. And that's also why in our neonatal testing, if you have mom's sample, if mom was tested at your facility, you can use mom's IAT results because the antibody will show up in her IAT. We will know what antibody it is, okay? And remember, when you're transfusing these babies, whether it be an in utero transfusion or a neonatal exchange, if mom has an antibody, those red cells that are used must be antigen negative, right? So if it's anti-big E causing hemolytic disease of the newborn, then if we transfuse that baby, it must be E negative red cells, okay? So the antibody comes from mom. The baby is antigen positive for which mom has the antibody, all right? So mom has the corresponding antibody to the antigen present on the baby red cells. And then the antigen is well developed at birth. So your Lewis's, your P1s, they typically are not well developed at birth. So that's why they're not a concern in hemolytic disease of the newborn. And as well as mom has Lewis A or B, we know that it cannot cross the placenta anyway, all right? All right, so your types of IgG, hemolytic disease of the newborn, the most common we see, anti-D. And again, remember the D antigen is the most antigenic, all right? So it will cause the most severe hemolytic disease of the newborn. So if you work at a facility where you have a high population of females that don't seek prenatal care and they have an active anti-D and their titer is actively increasing, the higher that titer gets, the more distress your baby is going to be in. Because that means there's more antibody coating baby cells. Those baby cells are being destroyed at an increased rate. Your baby's going to have severe anemia and respiratory distress, okay? So anti-D, again, usually only occurring in the second pregnancy. In the first pregnancy, that's exposure, okay? In the second pregnancy, now she has the active antibody. It will coat the baby cells if they are D positive. All right, so hemolytic disease of the newborn due to anti-D only occurs if mom is Rh negative and baby is Rh positive. All right, so if mom is Rh negative and baby is Rh negative, not a problem there because the D antigen is not there, okay? Only a concern if the baby has the antigen, right? And with your IgG antibodies, such as D, Kel, E, Duffy A, Duffy B, when we do our baby's DAT, and remember the purpose of the DAT, it detects what is coating the cells, and we've already established that it's mom's antibody coating the cells. Your DAT is going to be very strong, all right? Usually 2+ or 3+. All right, now when we look at ABO HDN, your DAT is usually very weak, like a weak plus or 1+. All right, so the DAT in ABO is weaker.
For Kel, would it still be 2+?
Yes, Kel would also cause a very strong DAT.
But not as strong as D.
And the reason that is, because if you think about what's causing ABO, hemolytic disease of the newborn, it's anti-A, B. And your group O patients, remember, they only build a small amount of A, B. So it's only a very small amount of that A, B crossing the placenta, coating baby cells. So your respiratory distress, your amount of bilirubin, is going to be decreased in A, B. However, in these IgG antibodies, usually there's more of the antibody being produced. So there's more capability for binding of these antibodies. Therefore, our VAT is stronger, and the symptoms of respiratory distress and increased bilirubin is more than caused by ABO. Does that make sense? It has to do with the amount of antibody that is present in mom. Okay. That's why when we start talking about titer, anytime we identify an antibody in mom, we will titer it to see how much concentration of that antibody is present. And oftentimes, let's say you do an ABO, RH, and an IAT on a mom at 16 weeks. That's typically when we'll first do an ABO, RH on moms. And we identify an antibody in mom at 16 weeks. We're going to titer it right then, right? And then at 28 weeks, when she comes back, we will repeat that titer on the new sample. If she has an increased titer, let's say maybe it's 28 at 16 weeks, and then it jumps up to 56 at 28 weeks, she's actively building that antibody. That concentration is getting higher. So we know baby cells are being destroyed, okay? Why is that titer getting higher? Because mom is actively being exposed to baby's antigen positive cells. So mom is building more antibody. Does that make sense to everybody? And again, anti-D is the most severe. So this is the case where oftentimes in utero transfusion or early term delivery will be necessary. This schematic just lets you know, it demonstrates what we've been talking about. All right, so here's your first pregnancy. Dad is Rh positive, meaning that he has the D antigen, okay? The mom is Rh negative. Dad is going to pass on that D antigen to the fetus. Mom is Rh negative, baby is Rh positive. In the first pregnancy, this indicates her first pregnancy right here. Mom is going to be exposed to some of baby's Rh positive cells during the natural delivery, and especially if there's any type of trauma. Okay, this is why we give Rogam to prevent her from building anti-D. However, if she does not receive Rogam, she will build anti-D. Okay, will have an impact on her future pregnancies. Notice now she has been sensitized. She has anti-D in her circulation. All right, let's look at what happens in her next pregnancy. Again, dad is Rh positive, mom is Rh negative. The fetus inherited the D antigen from dad, so the fetus is Rh positive. Mom now has anti-D in her circulation, which is IgG, can cross the placenta, can attack baby red cells. Okay, so now we have anti-D, IgG attached to baby red cells. The baby's spleen is going to take out those red cells. Baby has anemia. There's some red cell hemolysis occurring, increased bilirubin that's being cleared by the mom's liver. Okay, so bilirubin is not a concern in utero. Okay, so right now the only symptom the baby has is anemia, respiratory distress. Okay. And if it's anti-D involved, then and there's no treatment given, that baby is going to go into severe, as mom's anti-D titer keeps increasing, all of baby's red cells are eventually going to be destroyed. Okay, she's going to have that swelling from extramedullary hematopoiesis. They're trying to compensate for that anemia, but mom's antibody just keeps attaching to baby's red cells. All right, and so that's what causes edema, respiratory distress, and then that could warrant an intrauterine transfusion. We need to pull off those antibody-coated cells in baby and give her Rh negative cells, fresh cells, okay, to allow her oxygen carrying capabilities. Does that make sense to everybody? This is why your IgG antibodies are only occurring in second or third pregnancies. All right, they build it in the first one, not a problem for this pregnancy, but a problem for her future pregnancy. Okay, this is her exposure. But remember, ABO can happen. She already has those anti-A, B. All right, so it can happen in the first pregnancy. Yes, so baby spleens will destroy those antibody-coated cells. And the mom's liver, as long as the baby's in utero, will clear the bilirubin from that cell hemolysis. All right, so we talked about antibodies in this course. Remember, any clinically significant IgG antibody is capable of causing hemolytic disease of the newborn. Not only D, we focus a lot on D because that's the most common that we'll see in blood bank. And if a pregnant female does not seek prenatal care, she more than likely will build anti-D. Okay? But your other RH family, your big E, big C, little e, your Kel, your Tolano, Duffy A, Duffy B, JKA, JKB, those are all also capable of causing hemolytic disease of the newborn. So if it's Duffy A, mom is Duffy A negative, baby's Duffy A positive, mom could have anti-Duffy A, and it could also attack baby cells, causing hemolytic disease of the newborn. Okay, so don't think it's only D, but D is the most common, it's the most serious, and that is why we have Rogan as well. Okay. And then again, Lewis, P1, your I, and then Cartwright, your CW, which some of you guys have seen on your antigrams for your panels. Those are not considered to be well developed, so they are not a concern in causing hemolytic disease in the newborn. All right, so your ABO, hemolytic disease of the newborn, is most common. We will see this a lot in blood bank when we're doing a baby DAT. It'll be positive. You always have to look at what type mom is. If mom is type O, then and the baby is type A or B, that is when we will see ABO, hemolytic disease of the newborn. Okay. Typically, if mom is type A or B, she's not going to have hemolytic disease of the newborn due to ABO, all right? Because she does not produce that A, comma B, right? Only group O produced A, comma B, all right? And remember that that anti-A, comma B is IgG and it crosses the placenta. That's why it's a huge concern in group O moms. And remember, like I mentioned earlier, this can occur in the first pregnancy. And remember, these symptoms are usually milder. Typically, this does not result in a transfusion exchange. They might have to be under the light for a short amount of time, but typically it's not as serious. They might have a mild case of anemia and jaundice again, but it's not anything too concerning. And then again, the bilirubin rarely goes above 14 milligrams per deciliter. Sometimes you might even observe spherocytes on the baby's blood smear, and that's just because the baby spleen might be pitting that antibody off the cell, all right? Not completely destroying the cell, it might just be picking off the antibody at that specific site where the antibody is attached, causing a shape change in those red cells, causing a change in the protein structure, causing spherocytes, all right? And then your baby's DAT is going to be weakly positive, all right? Which is typically you'll see drastic difference between DAT due to IgG hemolytic disease of the newborn where it's very strong, all right? So if you think about, well, maybe my baby, if you have a O negative mom who delivers a B positive baby, she could potentially have ABO, HDN, and hemolytic disease of the newborn due to anti-D if she hasn't sought any prenatal care. But there's a theory saying that ABO incompatibility actually might protect against hemolytic disease of the newborn caused by the anti-D. And that's just because the anti-A, comma B is going to cause the cell destruction before the anti-D has a chance to act on those cells. Just a theory, but it could happen where mom has ABO incompatibility and anti-D. Sarah asked, even though they are both IgG, yes. All right, so what our testing looks like in blood bank. All right, so when we get a sample from mom, we're going to do our ABO-RH. That RH will include week D testing, right? If mom is D negative at initial scan, we carry through our week D and she comes up RH positive, right? Meaning that she's weekly positive. She is considered RH positive, right? She does not receive Rogan, and she is considered RH positive, all right? And then we'll also do an IAT. If mom has an antibody, then that antibody has the potential, and it's an IgG antibody, has the potential to cross the placenta if baby is antigen positive and attack baby cells, okay? If that IAT is positive, we must identify that antibody. And if it's an IgG antibody, we will titer it. And then we will follow mom. Sometimes if we identify an antibody, she is then classified as a high-risk pregnancy, right? She will have more frequent visits with her OB. She'll probably have her blood drawn more often, and we will continuously titer that antibody to see if it's getting higher. And your clinicians will use that titer to kind of measure the respiratory distress in that baby. So especially if it's anti-D and that anti-D is actively getting higher, that means mom is being exposed to those Rh positive cells and she is actively, continuously building the antibody. All right, so her titer is going up. A good rule of thumb is most facilities will consider if you have a twofold increase. So that means if your titer increases by twofold. So let's say if the titer on initial antibody identification was 1 to 8, and then she comes back in 2 months later and her titer is 1 to 32. Right, that would be a twofold increase. That is considered the antibody is actively building. That would be a concern. Okay. They will use the titer to typically to measure if baby is Rh positive, or not necessarily Rh positive, but antigen positive for anything. It doesn't have to be anti-B. And so here's your example of a titer. You take patient serum and add it into your first tubes. Your first tube is a 1-to-1, right? So it just has patient plasma. Okay, so it's a 1-to-1. You're going to add a designated amount of saline into your 1-to-2. So now you have a 50-50 mix of saline and patient plasma. You're going to perform a series of serial dilutions. You're going to take a designated amount from your 1-to-2, transfer it to your 1-to-4. All right, that's why it's a serial dilution. You will keep going all the way. We usually have the cutoff in blood bank at 1 to 256. Okay. And so your titer is positive in the last tube that has a 1+ reaction. Okay, so if your 1 to 8 tube gave a 1+ reaction and your 1 to 16 tube is negative, your titer is 1 to 8. All right. And so after you get your serial dilution, you mix each of these tubes, 2 drops, with antigen positive cells. All right, so whatever antibody you're titering, mix it with antigen positive cells, follow through AHG, and read for agglutination. All right, and then whatever tube has the 1+ reaction, that's your titer. Does that make sense to everybody? And it's the reciprocal. So that last tube that has a positive reaction. So if your 1 to 8 tube has a 1+ reaction, then your titer is 8. If it's still 1 to 32, then your titer is 32. Okay. So if in blood bank testing we reveal that mom has anti-D, her titer is demonstrating a 2-fold increase in that titer. Usually what the clinicians are going to do at that point, they're going to do an amniocentesis or a choriocentesis. We need to measure the amount of bilirubin that is being produced from this cell hemolysis. And so you guys know amniocentesis, they actually take the amniotic fluid, they insert a needle into the placenta and draw some amniotic fluid. Choriocentesis, they actually, it's also termed a peripheral umbilical sampling, pubs. And what they do is they insert a needle into the umbilical cord, and then they will pull off some blood from the umbilical cord. Usually if they do a choriocentesis, it's a very invasive, it's a very dangerous procedure. They use CT guidance to make sure the needle is indeed in the cord, all right, the umbilical cord. And then once the needle is there, they will draw off blood. Blood bank is usually on standby, all right? So usually if they're doing a choriocentesis, they want to measure the amount of bilirubin, and while that needle is in there, they can do that neonatal transfusion exchange if needed. Okay, so at that time they could pull out 25 mils of baby cells and then input 25 fresh cells. All right, so usually if they're doing a choriocentesis, blood bank's on standby. They're ready to give them the blood. Okay, so because it's a very invasive procedure, there's a lot of risk involved to the fetus. So usually what they do now is amniotic fluid and measure the amount of bilirubin present in that amniotic fluid. All right, so what do? They measure the amount of optical density. You guys ever heard of the Liley graph? You guys talked about measuring the optical density of amniotic fluid and then the lecithin sphingomyelin ratio. Yeah, you guys talked about that in chemistry? Okay, good. All right, so what they do is they use spectrophotometry to measure that amniotic fluid or that choriocentesis. So they have a known amount of spectrophotometry measurement for normal amniotic fluid. Okay, then they're going to measure your patient sample and get its reading. All right, so the more bilirubin, the higher the spectrophotometry reading will be. Then they take the difference. This is your delta optical density. So this would be your density difference, all right, from your baseline, from your normal, from your patient. All right, so that's your delta optical density, the difference. Then they're going to plot it on a Liley graph. So according to how far along your mom is, what week of gestation she is. All right, and so they really divide this Liley graph into 3 sections. Zone 1 at the bottom of the graph, usually it's minimal complications to the fetus. The middle is mild, but maybe we're going to monitor the fetus. And then if your result, your delta optical density occurs in this upper region, that is when a transfusion exchange might be warranted or even preterm delivery. Okay, so the higher your delta density and dependent upon the weeks of gestation determines the severity of the hemolytic disease of the newborn. All right, does that make sense to everybody? There's another curve, Queenan curve. It's a more recent release of how they measure the amount of bilirubin present in the amniotic fluid. It uses 4 zones, so unaffected, intermediate, moderate, and then if it's all the way up here, you know, this higher along, then this is where intrauterine transfusions be, and if up goes untreated, could result in utero death. So this is just another graph that they use, the Queenan. All right, so if your spectral scan indicates if you're in that top zone, in this area right here, they might do intrauterine transfusion like I mentioned, or they might do a early term delivery. They might go ahead and induce labor or C-section. whichever they decide. All right, so if they decide to do early term delivery, they will look at your leptin-sphingomyelin ratio. In order for early term delivery, this ratio must be greater than 2. All right, did you guys talk about that in chemistry? And that means body fluids? Okay, good. That means that the fetal lungs are mature, measures the pressure of the alveoli. The lungs are capable of delivering oxygen and not collapsing. All right, so once your LS ratio reaches 2, then the baby can be delivered. All right. So here's your pubs or your chordocentesis. Notice that here's your umbilical cord coming from the baby. All right, they take a needle, CT guided, all right, or ultrasound guided. They're watching that needle enter, and they want to make sure they're in that cord. All right, the baby's moving around in there, so you can imagine how dangerous this is. All right, that's why they use CT guidance or ultrasound, and that's why BloodBank is on standby. And they also want to make sure that they are pulling out fetal blood. So remember, mom's blood is going to the baby, and then also baby blood is coming out. So there's mom's blood in there and baby's blood. So they want to make sure they have baby blood. Hematology can analyze this sample that's being taken. Remember, babies have an increased MCV. Very common for fetal cells to be larger, at MCV of 110. All right, so hematology can look at that MCV and make sure that we're dealing with fetal blood. All right, and then once they ensure that it's fetal blood, measure the amount of bilirubin. At this point, they could do the intrauterine transfusion. They could pull off 25 mils and then push fresh cells into the baby's circulation. Okay. Does that make sense to everybody?
Jerica, did you have a meeting with this past 11?
Oh, I do. I lost track of time. So we'll stop here and we will resume here. I don't see you guys for the rest of the week because tomorrow is research day. We will resume next Wednesday, okay? Yeah, we will meet next Wednesday because I will be traveling to Washington, D.C. Hopefully. My family's freaking out. They don't want me to go.